recording right now, so you will see this recording button somewhere on the top. And I just would like to say that Journal Club is the place when we openly discuss scientific articles. And this is interactive, this is friendly, open space. And Valentina, today she's our moderator, and she would make us familiar with our rules. So let's begin. Valentina,
hello,
your turn.
Friends. I'm glad to greet you on our first Journal Club in this academic year. So my name is Valentina. I'm the 6th-year student of the first St. Petersburg Medical University. And actually I'm here because I'm interested in evidence-based medicine, and also it's a good chance to practice English. So today I'm going to introduce our speaker, Procenko Екатерина. She will tell us about the most debatable topic of this summer and autumn, about the new COVID-19 vaccine. And her mentor is Olga Anastasia Nikolaevna. She is infectious disease physician. And our head mentor is Vetrova Marina Vladislavna, doctor, psychiatrist, and narcologist. So about our rules. First of all, our meeting will be recorded, and later you can find this video on our official Journal Club website. So if you don't want to be on this video, not a problem. Please turn off your camera. And please stay muted during the presentation to avoid any annoying noises. But if you have any questions, you can interrupt the presenter and ask. So if something is still unclear, you can ask. Okay, no questions. So we're about to start. Екатерина, you're welcome.
Thank you, Valentina. My name is Ekaterina Procенko. I'm a 5th-year medical student of First State Medical University. And today we'll have a look at paper about Russian COVID-19 vaccine, which already made much noise. And name of an article you can see on your screen. So I'd like you to analyze this study with me. Why is it interesting for us? The problem is that we live in a COVID-19 pandemic nowadays. And secondly, this is the first one registered COVID-19 vaccine in the world. Thirdly, with a high probability, we'll deal with this vaccine in our lives because we live in Russia and it is our domestic vaccine. So also vaccination is very important because it could restrict the spread of COVID-19, reduce mortality, and decrease economical and social adverse consequences. So the article, here you can see, I think that some of you have read it. This article was published in the Lancet Online. Impact factor of the Lancet on 2019 is 60.4. It's very high. And this article was published on September 4th. Age index in Scopus of the first author of this article, Denis Y Logunov, is 14. So what the objective of this study? The objective was to assess safety and immunogenicity of the new heterologous adenoviral vector-based vaccine in 2 formulations. And the second objective of the study was to compare the formed humoral immune response with that recorded in people who have recovered from COVID-19. Later we'll speak about it. It was authors made 2 studies, and studies design were 2 open phase 1-2 studies, non-randomized, and they were provided in 2 sites in Moscow, Budenko Hospital and Sechenov University. One study in the first hospital and the second study in the second hospital. Let us look on participants of the study. The participants were healthy volunteers, which corresponding standard inclusion and exclusion criteria for such studies. Here you can see the inclusion criteria. They are very standard, and some of them like no history of COVID-19 or contact with patients with COVID-19 and negative PCR and negative immunoglobulin G and immunoglobulin M to SARS-CoV-2 are specific for this study. And other inclusion and non-inclusion criteria are very standard for healthy volunteers. Here you can see the non-inclusion criteria. On article, they don't provide them, but they were in clinicaltrials.gov. These studies registered there, and there you can see this criteria. So intervention of the study were vaccine. Intervention in different phases consists of either one component of vaccine or both components of vaccine. Vaccine consists of 2 components. The first, it is recombinant adenovirus type 26 plus gene for SARS-CoV-2 full-length glycoprotein S. The first is a viral adenoviral vector. It is a transport system for antigen. And the second one, it is an antigen. The second component of a vaccine consists of recombinant adenovirus type 5, also transport system, and the same antigen as in first component. These 2 components is made in one heterologous vaccine. This vaccine was produced in 2 formulations, frozen and lyophilized. And 2 studies were provided. Here you can see the name of these studies. Investigators made 2 formulations because frozen vaccine is hard to keep and transport, but cheaper and easier to produce. Lyophilized vaccine would be made for distant regions of our country. It is easier to keep and transport, but harder to produce. Recombinant viral vector-based vaccines induce humoral and cellular immune responses and can provide protective immunity after 1 or 2 doses. So it was the reason why authors choose adenoviral vector-based vaccines for COVID-19 vaccine. recombinant adenovirus vectors have been used for a long time, with safety confirmed in clinical studies of various preventive and therapeutic drugs. And also it was studies as a component of vaccines earlier. Also, long-time adverse events of adenovirus vectors were studied earlier.
Hello?
Here, yes.
Sorry, I have some problems with hearing you. It's only me or?
Looks like only you.
Okay,
I
sorry.
hear good. Okay.
Okay, sorry.
Here you can see references from article to studies where adenovirus vectors were used. Prime boosting vaccination. It is one of the standard approaches to vaccination regimen. For example, hepatitis B vaccination, CDAL, 0, first month and 6 months after birthday provided. Here, this scheme implies first priming the immune response or induction of a cellular immune response using DNA or a vector carrying the pathogen gene, and then immune response is boosted or a humoral immune response is induced, also using the vector or DNA. According to the literature, the timing between the administration of the prime and boost components is critical to achieving full protection. So we'll talk about this later also. Authors in the article say that since boosting vaccination is necessary for formation of a more powerful immune response, the effectiveness of such vaccination can be reduced when using a homologous vector because of formation of an immune response not only to the target antigen but also to the vector components. So authors decided to make heterologous heterologous vaccine consisted of 2 different vectors, and also provide heterologous prime boost immunization, priming with 1 vector and boosting with a second different vector. Here here you can see it. We have 1 vector type 26 and second vector type 5. Authors also provide us all important information about intervention. It was developed, produced, and manufactured according to good manufacture practice. They provide information about how much viral particles were in a full dose of vaccine. Also, they provide information about how it was administered. The comparison group in this study consists of convalescent plasma from blood samples of 4,817 people who had recovered from COVID-19 in Moscow. The plasma was collected from March 29 to August 11th. Interesting that blood was collected in average 1 month after recovery. Probably in some cases it was collected 3 or 4 months after recovery. It's not said. It can be. And we'll talk about later. Investigators collected plasma from people with mild and moderate disease severity. Why they choose such criteria? Maybe because people with severe disease have lower immune response, or maybe because severity of disease provided by antibody-dependent enhancement of infection, and people with severe disease would have much more immunoglobulin G in their plasma. It's not said here in the article. Authors didn't written anything about it. Here you can see primary outcome for safety. It is number of participants with adverse events. In phase 1, it was from day 0 to 28, and in phase 2, it was from day 0 to 42. Adverse events were registered daily. Primary outcome for immunogenicity was change from baseline in antigen-specific antibody levels at 42 days from day 0, when vaccination were provided, to day 42, measured by ELISA. This outcome concerns only phase 2, because only phase 2 were only the first phase ended on day 28, and phase 2 consisted of 42 days of assessment. Here you can see secondary outcomes. Neutralizing antibody levels, and measured on different time points, and determination of antigen-specific cellular immunity, measured also on different time points. Let us speak about study flow. At the beginning, 120 volunteers were preselected and screened. After screening, 100 volunteers were selected for 50 for each study, 50 participants for each study. Then participants who signed informed consent earlier were included in study. 76 participants were included that way.
Sorry, may I ask one question? Like, do you find in the article the time period between screening process and inclusion, like screening and inclusion?
No, I don't remember.
Yeah, I don't think that they say us like how, because I believe like on the screening they do lab tests, but it can be the window between like screening and exclusion, right? So it wasn't on the same day.
No, it wasn't.
Okay. I just think that it's exactly like the question which you point out on this slide, that it can be, I just think that they can enroll the patient who can contact like this person who have COVID, like between screening and inclusion. No?
Yeah, I realized.
Yeah. Okay.
It can be so, because nothing was written about these processes, timing of these processes. And then after inclusion, participants started self-isolation. But authors didn't characterize this self-isolation, where and how it had been done. but also they wrote that first 28 days after vaccination were inpatient. So we can say that 28 days participants were self-isolated in hospital, and in phase 2, after 28 days, it's not clear where and how they were self-isolated. Here, one study was provided in Budenko Hospital, a study with frozen vaccine formulation, and second study with lyophilized vaccine formulation were provided in Sechenov University. Both studies, 38 volunteers enrolled, and both studies, 38 volunteers ended. In phase 1 of both studies, 9 volunteers received one component of vaccine, and 9 volunteers received second component of vaccine, and 20 participants in each study received the whole vaccine, so both its components, like it would be in future if we would be vaccinated with it. All participants, like you can see here, all participants completed study. Here, study flow of phase 1. During phase 1 of both studies, participants received one dose intramuscularly of either recombinant adenovirus type 26 vector with antigen, or recombinant adenovirus type 5 vector with antigen, and were assessed for safety over 28 days. Adverse events were registered daily. Also, investigators examined antigen-specific antibody titer, neutralizing antibody titer, and cell-mediated immunity on 4 time points: day on baseline, or day 0, on day 14, day 21, and day 28. But on day 20, on 21st day of assessment, authors registered only antigen-specific antibody titer, the first one here. And phase 2 of both studies began earlier than 5 days after phase 1 vaccination. And let us look to the phase 2. During phase 2, participants received prime boost vaccination with one dose of vaccine administered intramuscularly on day 0, and one dose of vaccine administered intramuscularly on day 21st. Adverse events also were registered daily. Same immunity assessment, like in phase 1, was done on 5 time points: on baseline, on day 14, day 21st. Also, on 21st day, they registered only antigen-specific antibody titer on day 28 and on day 42. Here you can see baseline characteristic of samples. Note that phase 1 of this study with frozen formulation of vaccine included only men. Here we can see that this study female wasn't enrolled in this study. So this fact brings us to the first question. Is the study sample homogeneous? I think, to my mind, only in this case, with sample consists only of men, the sample wasn't homogeneous, and in other here on the second study, sample were homogeneous, and very,
and also ethnicity was primary. It was white, so
yes.
Sex and ethnicity homogeneous.
And all participants were fairly young, about 25, 35 years old.
But for inclusion criteria, they say that the upper limit of the age was 60, right?
Yes, 60.
So, but it's, for me, it looks like, what was selection process? Like, why they say that they use like registry of volunteer. So is it, why it's happened that they so like young? It's not looks like they cover the range between like 80 and 60 years old. And do you think it's because like usually like younger person more like willing to be a volunteer, or probably those who like older, they like met probably exclusion criteria, so that's why they was included, because it's hard to find healthy 60 years old person probably.
Yes.
But it's still kind of like, it looks like a problem, like, because who we need to vaccinate, right? So we know that older population at the risk, and we know that younger people, like, they probably survive better. So, and probably like we need vaccination for those who are older, not for younger. I mean, like, it's just the thought that
I suppose it is normal for phase 1 and 2 studies to include healthy volunteers, fairly young volunteers, to my mind.
Yeah, it's usually happened like in pharmacokinetic studies as well. Like usually it's like 30 years old men. Yeah,
but I'm also
like it's problematic too.
I also had this question about from which database the volunteers were preselected. They write about it like we had 120 people.
Yeah. I mean, like, what is the initial sample size, right? Like, how many people was like initially like volunteer to be in this study, and on
how they were recruited?
Yeah, how they advertise their study, and because I don't know about this. I mean, like, it's not looks like a very like a, how to say it, like low how to say it, как низкопороговые, да, программы, когда when I mean, like, when you have like it's like everywhere and everyone can participate. So, and in this case you have like presentive cohort of the like patients, but here it looks like very fancy advertisement for participation, and I don't know, probably
I guess that maybe it was only in Moscow, since they planned it as study here, so there were no case to advertise it widely.
Yeah, it totally makes sense, but again, like it's kind of like, you know, like everyone interested in this, and like even for I don't know, like in social media, you probably should like know about this, or like stop coronavirus website, right? Like how they, I don't know. So do you think that they just have like Moscow-based website for this advertisement? So probably
I know,
only.
but they start their website devoted to this vaccine only after the registration.
Yeah. Okay.
So another interesting questions that why authors don't characterize comparison group. For example, age of these people match their match to our sample here. Probably they were much older than the 30 years, and of course have different immune response and other covariates could be also. No characteristics of the comparison group.
So when you say comparison group, what do you mean? Like comparison between like two vaccines or two formulations?
I mean those people which plasma were collected.
I see.
What are characteristics of those people? They only characterize these their disease severity, and that's all. And also average time about their recovery and plasma collection were in some cases probably can be could be much more longer than it is when optimal. The third question is the choice of the primary outcome justified? What I mean, why authors choose antigen-specific antibody level as primary outcome? We know that high level of immunoglobulin Gs with small level of neutralizing antibodies can provide antibody-dependent enhancement of infection. And high level of immunoglobulin G not also good enough, maybe not good enough in this case. And maybe it would be better to look at immunoglobulin G and neutralizing antibody ratio, or maybe they could choose neutralizing antibody as a primary outcome. And also the last question, is the time interval between administration of prime and boost components optimal? Because as I said, the interval, the timing between the administration of prime and boost components is critical to achieving full protection. And here they choose 3 weeks, and probably it would be better to make another time interval and to see how it would be working. Maybe it would be investigated in phase 3 studies.
Do you know what's happened with a person when they enrolled in the study? Like what life they lived after vaccination? I mean, like, do they also self-isolated after like first dose of vaccination, or do they actively like participate in public life? Like, you know, because I don't. Yeah. So what's happened after they enrolled in the study?
They were hospitalized after the first vaccination for 28 days.
Yeah.
But
so,
after 28 days, who knows? So they've received 2 doses during this time. And for these 28 days, they were hospitalized.
So it will be interesting.
It's not like real life.
Yeah. Do you think it's problem to interpret the data?
I think that it's a right way to isolate them from the risks of COVID-19. And I don't think that it can so so I think that it's okay that they were not included into like real life activity.
Yeah. And what do you think about like this like final question, because I actually don't really like expert in this, and like I actually don't really know the proper answer for like time interval between administration. Those like I just interested to know like what does infectious disease doctor know and like how they feel about these intervals. Is it enough? Like it's would be good to have like longer periods or shorter period, or and what is the justification for these time intervals that were used? Because for me it's like not really clear like why we need to wait like
for me, we've choose this interval just because it's a standard interval between these doses, like for other vaccines, because we haven't checked for other variants here.
Yeah. Okay. Is anyone have some like thoughts or questions or in this point of our discussion? If not, I have one, like probably when other people think that why, so probably it's super stupid question, but why we need to compare two formulations? What is the reason for like for this? Probably I missed this.
Yeah, I guess you missed.
Yeah. Can you explain it like to audience?
It only related to the situation that frozen vaccines are cheaper and easier to produce them, and the lyophilized vaccines are more expensive and it's more difficult to produce them. But if you need to vaccinate someone on the deep north or in some regions with low, how to say, с плохой доступностью, отдаленные регионы, you need lyophilized one. For other regions, frozen is good. That's why they need two formulations. And of course, you need to check every from these two. Does they work or not?
Yeah, makes perfect sense. So yeah, thank you.
I have a question about the adverse events. Did the authors mention it? Were they severe or anything else?
They mentioned, and it would be later in results.
Okay.
We didn't speak about results. And now we can speak about results of safety. In both studies, systemic and local reactions and changes in laboratory variables were among the adverse events. Most common systemic and local reactions were pain at injection site, hyperthermia, headache, asthenia, muscle and joint pain. In volunteers who received both vaccine components, most adverse events occurred after the second vaccination. No serious adverse events were reported, and all participants were clinically well throughout the study. So all adverse events in volunteers were mild and moderate. In general, adverse events identified during phase 1 and phase 2 of both studies are typical for most vaccines, particularly those based on recombinant viral vectors. So that's all results for safety. And here we can see results for immunogenicity and for humoral immunity. On the first figure, you can see RBD-specific immunoglobulin G's reciprocal titer on volunteers who received both components of vaccine, the whole vaccination. On the left, you can see frozen, those who were administered frozen vaccine, and on the right, lyophilized vaccine. And here on figure D, figures for neutralizing antibody reciprocal titer. I present only phase 2 results because in phase 1 only one component of vaccine was administered. And during phase 2, RBD-specific immunoglobulin Gs were detected in 85% of participants on day 14, and in 100% of participants from day 21. It is data for both frozen and lyophilized.
So you say that this is like on the slide you said significant difference on days 28 and 42. So it compared to what? To baseline or to the previous visit?
It compared to convalescent plasma, to comparison group.
Oh. Mm-hmm.
The primary.
But the primary outcome was changed, no?
Yes,
changed
primary outcome was changed, and change were detected on 100% of participants, and the mean level on day.
How much was defined?
What is the question?
And how change was defined? Like change on like 1 or on 10 or on 100, like what was the change? How it was defined?
On day 0, you can see that everybody have 0 level of these immunoglobulin Gs, and on day 42 the mean level were 14,703 on frozen formulation and 11,143 for lyophilized formulation. So the change were big change. Like thousands of immunoglobulin Gs were measured. Mm-hmm. And when authors compared it with results from convalescent plasma, they showed that post-vaccination ELISA titers was significantly higher than were titers after COVID-19. Mean levels. The mean is this black line. Here you can see it. Analysis of neutralizing antibodies showed that administration of both components led to production of neutralizing antibodies in 100% of participants on day 42. And here you can see the levels of titers of neutralizing antibodies, and authors note significant differences in neutralizing antibodies between study participants and convalescent plasma were not seen here. And also authors notes a strong correlation between SARS-CoV-2 RBD ELISA titers, the first one, and neutralizing antibody titers, the second one. So, like when these immunoglobulin Gs raises, the neutralizing antibody also raises with a strong correlation. Here results for cellular immunity. Cellular immune responses showed formation of antigen-specific cells of both CD4+ helpers and CD8+ cells, T killers, and an increase in the concentration of interferon gamma secretion in peripheral blood mononuclear cells in 100% of volunteers on day 28, I suppose. But here on figure F, I can see that not all participants have interferon gamma increases. 2 dots on 0 line, I suppose. Cells from vaccinated participants proliferated significantly in response to glycoprotein S, particularly on day 28. Here, on those figures B and D, the third one, you can see it. It is the day 28. Cell-mediated responses were detected in all participants at day 28, with median cell proliferation of 2.5%, CD4+, and 2.3% CD8+. With a frozen formulation, it is figure B, and a median cell proliferation of 1.3% CD4+ and 1.1% CD8+ with the lyophilized formulation. This is figure D. So why authors didn't compare to convalescent plasma cellular immunity? Nothing was written about it. I should say that on 7th September, an open letter to Denis Y Logunov at authors was published on the internet. Here you can see the website. Its authors pay attention to cases of data duplication on figures provided in study. It is figures for phase 1 studies. they marked these duplications in color boxes. In the red boxes, 9 out of 9 volunteers challenged with recombinant adenoviral vector type 26 plus antigen appear to have identical antibody titers at 21st and 28 days. Here you can see it on figure A. This is also true for 7 out of 9 volunteers challenged with recombinant adenoviral vector type 5 in yellow boxes. And furthermore, in the cyan boxes, we can see all the experimental points differing for a constant value in 2 completely unrelated experiments. So it is rather different figures. It is figure 4 frozen formulations, figure 4 live formulation, and the vaccine components of vaccine were different, but dots are the same. Authors pay attention to this duplication of data. While we understand that in this case the variable under study is discrete, so points are discrete, not continuous, it seems to us that fact of observing so many data points preserved among different experiments is highly unlikely still. Still, authors suppose that it is rather unlikely. For figure 3, intended to present the results of the cellular response to the different formulations used for challenging the volunteers. In the following reproduction, repeated experimental points patterns are boxed. Also, authors boxed cases of duplication of data. But in this case, the variable is continuous in nature, and such duplication couldn't be in nature. Like, it is less likely than in figure 2 here. And the fourth figure, which is intended to show the neutralizing antibody formation against the adenovirus vectors used for the vaccine problems like those observed for figure 2. So here we also have discrete variable and cases of duplication of data. We authors of this letter suppose suspecting.
So do you familiar with any response to this letter from Dr. Logunov?
Yes, Denis Logunov promised colleagues to provide access to the research, to the whole research protocol. It was on 11th September, and now I didn't see nothing about it.
Because I also see that like in case that you have like it was somewhere in the paper that it was the state of author that if you would like to like ask me a question and to have access to individual data, it's like is very welcome. So it looks like if you it's strange that like it's open letter, and I mean like if you do this like open letter you would like to attention from public, but why don't you if you have the ability to ask the author and to ask them to have access to the data, why don't you do this and present you and do just your own analysis and to see what you get? Because I think that when you publish to Lancet, you always have like you are being in position that in any time like a reviewer or someone can ask you to provide actually database, like data set with like real data. not your results. And like it's like policy of the journal. So I think to making this kind of comments like in open letter rather than to ask author to provide the access to the data set and do your own analysis and then publish like your own analysis and to do this. Like, I mean, so for me, this is kind of strange because again, like it's no like follow up with it. So for me, it looks like like advertisement of the office of who write this letter, because it's a very hot topic, right? And if you don't do your own vaccine, you're trying to to be involved in this.
Oh,
and I totally agree that it totally makes sense, and I just applaud their ability to find these like unique features of the figures. It's totally makes sense. But for me, it's again strange that you can ask the data set and do your own analysis. So why don't? So
very
and I yeah.
Sorry, I just let's say that very good words. I like your point of view, and I'm agree totally that it looks much more as an attempt to receive some your own benefits from this lecture, even than to make something more clear. Yep.
Mm-hmm. Yeah, it's I think in this point of you see that how science can be also involved in like political games. So and it's like have social component. Like even if we do some like biological studies and we're thinking about okay, like this probably nothing about social influence, but it's still like yeah. I think science.
Told yesterday they published the continuation of this lecture, and if someone is interested, it is published in the Lancet too. Like we read first one, and now we want to say even more.
Yeah. No, it certainly makes sense. Also, like the discussion is one of the like why we all involved in science, and right now we also like discuss. So discussion science is like totally normal process, and it's yeah, and everyone do this for their own benefit and also for the name of the science. And yeah, but like, is anyone and I feel I really think that this letter just show us how we can be easily fooled, and how that we should pay attention actually on what we see on tables, not just like okay, this is like looks like good figures and like it looks serious and it's good journal. You again, like even if it's like good journal with a very high impact factor like 60, it's like very high, and but still you should be like not influenced by this factor and be as much objective as you can, and to like very careful to see what is exactly the data and how it's like different. And I just feel it's really like good attention skills of the scientists, which we can like also learn how to do this. Okay, what is your like common idea about these results? Like for me, it looks like brilliant results, and like vaccine is working, and everything looks so perfect and good. But what other people think, and maybe you have some comments and notice something interesting. I would like to see, yeah, Ekaterina, please go.
I also read somewhere that one of authors of this open letter have conflict of interests about vaccines on COVID-19. I don't know.
What do you mean about conflict of interest?
Probably he's an employer of some farm company.
Because in declaration of interest in the paper, there are no words about this.
About open
Right?
letter.
Sorry.
Open letter authors.
I see. Sorry.
So probably it is the more mostly not scientific but more political or social. But cases of duplication here we can see.
Yeah. And do you feel not really comfortable with this? Like, I mean, like, if you don't see this open letter, do you think that you will pay attention on this and it would be problematic for you to interpret the results? I mean, how you personally feel about it?
Maybe it would be suspicious for me to understand the whole article. But these results are from phase 1, and all these results where authors of this letter see cases of data duplication, they are from phase 1, and this wasn't a primary outcome for authors of this article. I even don't know why did they do these figures. It wasn't their aim to show us immunogenicity in phase 1. They couldn't do these figures, and that's all.
Okay. How other people feel about the presented results, and please tell us what you're thinking, or even if you have any questions. And I mean, about the sample size, I feel I feel okay about this. I don't feel it's limitation of this phase 1 and 2, and because it's kind of also standard. We don't need 1,000, so it's different. It's again it depends on your goal of the aim of the study, and for this aim, for this phase, it's okay to have this amount of person. I just feel it's very it's preliminary data to see do you need to continue to study this or not, and this is exactly its answer us this question. It's exactly we need to continue on larger studies, on the cohort studies and real settings. So I would probably just don't really agree with that it's limitation. Yeah.
And most of all, authors write to us that 16 was an optimal number to assess immunogenicity, and it was mathematically measured by authors. And so I also don't think that it is limitation.
Yeah.
I guess maybe it's much more limitation for registration of the vaccine as usual, but not for this study. Of course, for phase 2 and 1, it's okay. It's only the discussion about the registration.
Yeah. Okay. Any news about the other vaccine in the world? What right now science thinking about vaccine? Because I also just recently watched some video with Trump, who think that it will be ready in early October, and it will be open access for public, and but actually scientists think that, and the person from CDC said that he's probably wrong, and we don't have it like until like next year. So what is your like last news on this field?
As I know, a few vaccines from China are in the third phase right now, even in St. Petersburg, with good results. And that means that nearest time, I guess it may be nearest year, we obtain some effective vaccines, and it will not be only one vaccine. I guess it may be different, and we will have maybe a choice, but I think that no.
Maybe we will have choice.
Yeah, I know, but the first limitation will be, I guess, for this like Chinese vaccine as the Asian ethnicity or something like it. But that is interested that their third phase are right now in Russia, so they include not only Chinese people in this study, but people all over the world.
Yeah, and who do you think will be target for vaccination? Like, do you feel that it's like everyone should have get their vaccine, or it's probably only those who
I guess we start from medical specialists. I guess we will start from doctors because they are at risk group, but they are rather healthy in comparison with another risk groups.
Yep. Yeah, sounds like a fun. Okay, is anyone want to share some like last words, because we are kind of a little bit over time, and thank you for your talk. Okay, Natalia Katolikova, thank you a lot. And actually, I would like to make two, like probably you just like thinking about like what you can say, and I in this time just make two what to say, suggestion. If you would like to present on Journal Club, please do. Please contact with Marina Irhina, and it's very welcome to practice your English, to practice critical analyzing skills. So please join us. It's very open, and we try to involve as much student as we can, or not student, like also doctors. So if you think that someone will be interested in participating in Journal Club as a presenter, please let us know. And second thing, that after this Journal Club, we do one of our traditions. So we send you a survey, and I know that probably most of you already did it in the past, but I think probably if you have like new things to say, it will be nice if you again fill this form. Yeah, I think that's it. So let's return to your questions if you have one. Veniamin, this is your first time here, so share with us like what do you think, and what is your like take-home points from our session, if you have one. Veniamin, you are muted right now. If you unmuted, it will be nice. Oh,
well, hello. This was a pretty complete and good report about this article, and I like the atmosphere here, and I like that everybody can ask questions and get their answers. I think that this is a good practice in our university, and I'll be glad to be on your future journal club meetings. Thank you.
Perfect. Thank you so much. Okay, just let us know if you would like to be presenter one day. So it's very welcome.
Well, maybe someday, yes.
Okay. I also see other new names. Don't see faces, but names. Ася Malykina. Sorry if I don't say your name correctly. So can you say us what do you feel and how it was for you? Ася, you unmute. You can unmute yourself. Just push the button like unmute, and we can hear you. Then. Okay. Okay. I recorded this video. It will be available soon. So probably those who couldn't participate live can watch it later. I think this is it was very interesting paper, and I truly recommend you to have this paper on your hands when you read, when you write your own articles, because I feel that how they present data, how they do these tables, like except the fact it was kind of like duplicates, probably, I don't know. So anyway, I feel that how they present data, it's really good shape, and they provide all information on the tables, like, and I feel it's one of the example of good work. So totally recommend this to do in the future. If you don't have—
May I ask the question? I wanted to ask the question to Anastasia. Should we believe that this vaccine wouldn't have some long-term adverse events if these adenoviral vectors in previous studies didn't have some serious adverse events? And should we believe it, and or no?
As for me, if some adverse events should be, it will not be related with adenoviral vectors, since we know adenoviral vectors good and it's not a problem. But we still are not so good in the anti-COVID-19 immunity, and we are not so deep know its specificity, and we do not know enough about cellular immunity. And what is more important, yes, sure, neutralizing antibodies are important in this request, but who knows about the full picture of this immunity reaction. And it means that only after we see the result, when these people who formed their immunity meet the virus, and how it will come after, we will understand how it works.
Yeah. So your main concern is not safety, but efficacy, right?
Efficacy and the result of the disease course in case of this vaccination. So it's a bit about safety too, but I have not so big concerns about it.
Actually, I also have one question to Anastasia. You have told that there are several researchers in China. Also, they try to develop vaccine, and they are already on their third phase. But they are not, don't have any registration. But our Russian vaccine got the registration only after the second phase. How does it work? So why?
Oh, it's uncommon station. It's the rules which was happened due to pandemic. They just create the law which make it possible to register vaccine after two phases. Like we think that it is safe and it is working, and the risks are lower than the risks of a pandemic continuation.
But the question why other countries don't do this, like don't break these rules because it's pandemic and have this.
Who knows? I know that USA maybe have something like it, ability to register something up to two phase in this case of situation. Not sure. Maybe they really haven't so good results right now. Who knows? After two phases.
I see. Thank you, Valentina. Good question. Good question. Okay. So I think that's it. So I really thank our first presenter. So it's like opening ceremony today has happened. So thank you, Ekaterina, and big thanks to Anastasia to helping with it and to answer to all us to all our not very easy questions. So we are looking forward for second wave. No, I'm not. So probably, hopefully it will end soon, and we will be. Hope you all safe and yeah. So thank you a lot. Okay, bye bye.
Thank you.
Thank you very much for listening. Goodbye all.
Bye bye.